Thank you for joining us this morning. We are waiting for folks to trickle in, and we will get started in a few seconds. Welcome to the UCLA HIV Grand Rounds. This Grand Rounds, just to give a brief overview, is offered by UCLA Center for HIV Identification, Prevention, and Treatment Services, the UCLA Charles R. Drew University CFAR, and it consists of an hour-long lunchtime lectures that are delivered by invited guests on a broad range of HIV-related topics. The aims of the Grand Rounds are to share the latest research findings on HIV prevention, care, and treatment, and highlight important developments in HIV-related research, to encourage scientific collaborations and networking, and to also excite an interest in HIV/AIDS research, especially for early career investigators, and provide resources about new research findings, funding, and career opportunities. Thank you for joining us. We have this Grand Rounds every month at exactly the same time, 11 a.m. to 12 p.m. Pacific time. Some of you might have been in previous Grand Rounds, and some of you might be joining us for the first time, so we welcome you. My name is Damilola Jolayemi, and I am a program coordinator at the Center for HIV Identification, Prevention, and Treatment Services. So we can go ahead and get started. I think we have at least most people in the room with us today. So we can go ahead and get started. Today, I will go ahead and introduce, first of all, our moderator, who will moderate this session today. Our moderator will go ahead and introduce our speaker of the day. So our moderator for today's Grand Rounds is Dr. LaShonda Spencer, who is the professor of pediatrics and internal medicine and an ID specialist, and the director of Drew Cares, which is the Center of AIDS Research, Education, and Services. She's also MPI for the CDU UCLA CFAR, and the clinic director for Martin Luther King Oasis Clinic. Go ahead, Dr. Spencer, and moderate the session. Thank you for joining us today.
Thank you very much for the introduction. Thank you everyone for attending our Grand Rounds today. I am very pleased to introduce Dr. Ifeoma Udoh, a senior research scientist at the Education Training and Research Center, which is a Black women-led organization whose core mission for over 40 years has been centered on the advancement of health equity for families, youth, and communities through science-driven education, training, and research. She has extensive experience in implementing international and domestic HIV/AIDS programming and monitoring and evaluation activities in low-resource settings around the world, including the Caribbean, Asia, and the United States. In her role at ETR, she leads HIV content area, driving overall agency strategy to address the development of ETR's HIV products and scientific services. Dr. Udoh, for nearly 20 years of her career, has worked at the intersections of applied science, culture, and people and program strategies on how best to integrate and channel the stories of diasporic communities to drive public health solutions and health systems change. Dr. Udoh is a proud graduate of the University of California System. She was a double major, Bachelor of Science in Microbiology and Molecular Genetics at UCLA, and holds a PhD in Medical Anthropology from UC Berkeley. Go Bears, I'm a Berkeley alum. She uses her deep qualitative expertise in designing HIV and sexual reproductive health prevention and care programs, and to address systemic inequities in healthcare access for men who have sex with men, sex workers, Black women and their families, and people living with HIV/AIDS in both international and US-based domestic settings. Welcome, Dr. Udoh. It's a pleasure to have you here with us today.
Thank you so much. I'm really honored to be here, and I see some familiar faces, so thank you all for joining and supporting. Again, my name is Ifeoma Udoh. I am a senior scientist at an organization called ETR. I'll talk a little bit about who we are as an organization. But really, this talk is, I hope, meant to add a sense of reflection and a sense of, and some tools for integration into our work as researchers and scholars and health activists. I consider myself not just a researcher, but I also consider someone who deeply sits in the sort of integrated role of how does my research and how does my evaluation expertise really drive activism and action. And so I'm happy to be here to talk about ETR's health equity framework from reflection to integration and action for HIV research. By the time I hope we are done with this session, I'm going to skip some of the animation. So if you see me flying through it very quickly, that's me not liking animation in my talks. So I apologize for that. But by the time at the end of the session, I hope that there's an understanding of the foundational aspects of ETR's health equity framework, that we can all identify some lessons and tools to advancing health equity in HIV, especially for BIPOC scholars, researchers, and activists, and that we can identify and develop an action in applying health equity and applying the health equity lens framework directly to your own work. So really at the end of this talk, I'd like folks to walk away with something that they can do, or acknowledge what they are already doing, and then how can they advance that further with regards to applying a health equity framework to your work. So very quickly, ETR is a nonprofit organization committed to improving health outcomes and advancing health equity for youth, family, and communities. We have been around for 40 years. We're going into our 41st year currently. Oops. And we were started in California when a set of Planned Parenthood providers were starting to feel like that Planned Parenthood was becoming very medicalized in their approach and sort of taking that sort of aspect of education around sexual reproductive health care. And so they came together and formed a nonprofit that was really sort of to drive that idea of how do we be inclusive around sexual reproductive health care. And it's been around for 40 years. Our current CEO, Vinetta Charles, was a former ETR employee and then came back to become the CEO of the organization 6 years ago. So we specifically focus on a set of content areas. We have a core set of content areas that we focus on in terms of our mission around advancing health equity. Those four are HIV and sexual reproductive health, alcohol, tobacco, and other drugs, school-based health and wellness, and equity inclusion in STEM-based careers, particularly centered on BIPOC communities and women, young women. We use a number of strategies to advance our mission: applied research, evaluation, technical assistance, training, and capacity building. For a number of years, ETR has been a SIVA provider and is under its HIV services work with the CDC. We also have a CDC Evolve program right now where we're implementing work on e-learning for HIV programming. We're one of the e-learning providers that CDC funds currently. Program development, health promotion products. ETR is the largest provider of health education materials in the United States. If you've ever gone into a school-based health clinic, or any number of private clinics for that matter, if you look on the back of one of those pamphlets that they have sort of on that pamphlet wall of all that education material, it's likely that it's ETR was the producer of that. And we also use evidence-based program dissemination and disseminate our curriculum, particularly our Health Smart curriculum and our About Us curriculum widely in school-based health centers. And so I'll talk a little bit about that work as well. So moving into this sort of idea and discussion about what is health equity, I'm not going to spend a whole lot of time on what is health equity because I'm hoping that a lot of people here know what that is. And so I'm going to invite you at this moment to place a bullet or two to prime your brain. What is health equity to you? Before we get into the conversation, I want to push people a little bit to tell us what they think it means. So I'm going to go silent for a second. Health equity, anyone? I don't see anything popping up in the chat. Yep, access to care. What's the difference between equity and equality? A number of you have seen these slides before in terms of thinking about the difference between equity and equality, that leveling of the playing field. Thinking about community resources as being equitable across all communities and structures and access. Asking another question here, how does equity show up in your work, in your research, in your organization, your collaborations? Can you name an example of how you stay curious in equity and how you engage in equity practices? It's a lot of quietness going on in the chat. Mobile units. How does equity show up in your collaborations? Pipeline programs, interdisciplinary. I'm going to talk about some, yes, I love that one. Explicitly make clear to your team that everyone has someone to bring to the table, regardless of educational level. I love that one. That's one that we use a lot at ETR, and I'm going to talk about some of the examples that we have in terms of infusing equity in our organization that could be useful here as well. So again, metaphors are important. They help us understand new ideas by referencing the things we already know. At the same time, they shape our experiences, opening us up to some new ideas while maybe closing us off to others. And one sort of in place of inspiration that I find in my work is, as an anthropologist, I love the work of Zora Neale Hurston. And she pokes at us a little bit in terms of thinking about what research is. In her book, Dust Tracks on a Road, research is a formalized curiosity. It's poking and prying with purpose. It's seeking that he who wishes to may know cosmic secrets of the world and that they may dwell with therein. And so I think as researchers and as scholars and as activists doing this work, we have to stay in that place of curiosity, particularly when we're thinking about health equity and how it applies routinely and constantly as a measure of practice. And so I'm going to give some examples of how we do that at ETR, and hopefully have you all generate some examples of how you could do that within your work as well. So you've seen these definitions of health equity, that it's achieved when every person has the opportunity to attain his or her or their full health potential. Health equity means that everyone has a fair and just opportunity to be just as healthy as possible. We saw some of those examples come up in the chat, so thank you for those. I think the ones that are important to sort of highlight are what you see highlighted here, that fair opportunity, that no one should be disadvantaged, that every person has the opportunity, that things are fair and just. And I think in this sort of time that we're in, where there are lots of questions around what's fair and just with regards to health equity, particularly in times of laws taken off the books so that women don't have access to make sort of equitable decisions for their own bodies, I think we are that much more pushed as researchers to really engage in these conversations and in these practices and tools across our teams and across our work. I think it's that much more critical for us to be in that health equity space. So again, components of health equity, the definitions of those things, fair access to conditions and opportunities to achieve the highest standard of health, and removing barriers and creating access for those at the greatest risk of poor health resulting from social conditions. Context is important. And so how do we constantly stay in a space of ensuring that context is driving what we need to know about the stories of what these barriers are that are creating lack of access? So I think that's really important as well, and I'll get into some discussion around that. Health equity versus inequities or disparities is aspirational, right? And so health equities, as that quote that Zora Neale Hurston asked us to stay in that curious space, right? That we have to stay constantly in that open and curious space. and that it represents that commitment to really address and eliminate health inequities. And so those are things that I think are incredibly important as we sort of drive towards what a tool and what reflection and action could look like, is that really it's about the big picture dreaming, like how do we dream these things? Health equities, health inequities data measure progress towards health equity. Social determinants of health versus health equity. These are all definitions that I know everyone on this call has likely seen before, but I think it's important to set a context for how we think about the determinants of health, and understanding sort of the difference between distal and upstream issues versus proximal and downstream issues, and what the relationships are across that. So we think about societal structures, community environment, relational, behavioral, which is a big place for us, I think, as behavioral researchers and scientists that have worked in that sort of space. And how do we sort of shift our work, which I think we're seeing a lot more now in HIV research, obviously, in terms of structural interventions, and thinking about sort of the genetic and physiological factors as well. So just being conscious and aware of those distal upstream versus proximal downstream concerns as we develop and design our research, I think is incredibly important. So why is using a shared language critical to advancing health equity? Any thoughts? Why is it important to recognize health equity versus health inequity? That power shift and that dynamic between thinking about strengths-based and resilience-based work, which is equity-based, versus thinking about problems and thinking about issues. Why is that important? Any thoughts? I'll keep going. Organizations must understand the cultural and political resonance of racial and health equity concepts with their communities, and the extent to which clear definitions of terms and concepts will foster a health equity agenda. I think these are really important issues as we drive towards thinking about tools. And so with that, I'm going to go into describing ETR's health equity framework. I love that. That those thoughts that are popping in, assumptions that there are problems is a big one. I think moving out of that assumption space, particularly when we're working with community, is incredibly important, and recognizes the multidimensional nature of groups in the context with which we work. Thank you for those examples. So I'm going to launch into talking about ETR's health equity framework, and then offer up some ideas for how we use the framework. The health equity framework was designed and developed at ETR. You can find it on our website. It's also been published in a peer-reviewed journal, and that's also posted on our website as well. The health and education outcomes of our health equity framework sort of lie within this idea that there are complex interactions between people and their environment, and really sit in this sort of space of thinking about those complex interactions around four spheres of interaction. Yeah, changing the narrative from them to us, correct, yes. ETR's health equity framework is based on 3 foundational principles: that equity is at the core of all health outcomes, and that there are multiple interacting spheres of influence, and that there's historical and life perspective that influences all of those outcomes, that influences the entire sphere. And so again, when we think about how we enter into spaces as researchers, I think it's incredibly important that we acknowledge that the spaces that we are entering into have historical contexts that are impacting the life course of communities and individuals and people and systems. And so thinking about how that is all interacting all at once while you are implementing your work is an incredibly important task, and a heady task, I think, for us as researchers to be in a space of. So the first principle of the health equity framework is that equity is at the core of our health outcomes. we think about personal agency and we think about fair access to resources as health equity. And so really sort of centering how we approach individuals, but also centering how we approach individuals having fair access and opportunities. That means health equity. That's the core. That is the basis of how we set all of our work at ETR, and the basis of, I think, of having a health equity lens in terms of your work as researchers. The HEF transitions. Yep, I'm going to get into that. We have some organizational agency or system agency examples as well. And so the HEF transitions this focus from centering the individual to centering and moving towards health outcomes of communities and groups. And principle 2 is about these multiple interacting spheres of influence, is what we call them. And we have 4 for the health framework: relationships and networks, which are the connections with families and friends and partners and community and workspaces. We're all part of these like relationships and networks, right? And that's a sphere of influence. The individual factors, which I think is where a lot of what historical HIV research and activism has sat in the space of individual factors. We want to push and constantly push ourselves to thinking not in that sort of dichotomized way about relationships and networks versus individuals. They're all interacting. So the person's response to social, economic, environmental conditions through their attitudes, skills, and behaviors. That probably likely sounds familiar to a lot of us here doing HIV research. And then the psychological pathways are the biological, physical, cognitive, psychosocial abilities that can contribute to health, but can't be easily modified. And again, these are places that I think as researchers, we've sat for years, a lot of our work in trying to sort of shift both the individual, the psychological pathways. And so what does that mean? That we sort of move in this direction towards thinking about systems of power, which is the hardest one to change, right? Like systems of power, the policies, the processes, the practices that determine access and determine resources and opportunities. That's the push. That's the space that we all should be thinking about in terms of how our work addresses those systems. And it's the hardest one to latch onto. You know, we as researchers have sort of sat in that individual and psychological place, but how do we sort of think about the systems that are influencing all of those connections? So again, systems of power, processes that determine access to resources and opportunities is the main system, the way that we sort of think about how systems impact opportunities available to us, how they impact opportunities available to community. Relationships and networks, connections with family and friends and partners and workplaces, all of those things have influence on how we operate in the world. We're not individuals without places that we go and people that are in our lives and things that are influencing our lives. And so how do we address and stay connected to those relationships and networks, and how do we sort of drive a health equity approach to those things? Individual factors, a person's response to social and economic and environmental conditions through their attitudes, skills, and behaviors. And then the psychological pathways, again, are the biological, the physical, and cognitive places where these contribute to health, but are not easily modified. Then this is again thinking about, you know, mental health concerns within our communities, particularly in light of COVID and what's happening across the world, I think, in terms of people really struggling with how to sort of reconnect and how that all has influence in terms of the work that we do as researchers. So really when we think about the HEF as a model, there's a lifespan approach to the way that we think about the HEF. The HEF is not just this sort of thinking around health equity in these sort of separate spaces, that it's over time. It's from adolescence, it's from youth, really, it's at 0 to 5. I'm the mom of a young kid, so like it's that 0 to 5 age until moving through adolescence. And then what happens within those spaces of being an adolescence and your family of origin, what you're influenced by, what you have access to in those spaces. Really thinking about health equity and approach around health equity is about a lifespan approach, that it's cumulative and it's generational, that it's impacted by historical access, by inequities, by trauma, and those impacts also have impacts on future generations. And so it's that continuum of work of thinking about where do we intercede as researchers and what do we hope to accomplish in our work across that continuum. These are big ticket questions that I think we should all be asking ourselves. What are the health and outcome inequities that we want to change? How do the spheres of influence impact this outcome? What are the strategies that we and others currently using to address the spheres of influence? And I hope to talk a little bit more about that and get some examples from the audience of what strategies you're using in your own work as researchers. And we have some strategies that we're using at ETR. And then what are the gaps in our strategies that can increase our impact on inequities? The way we use the HEF at ETR is a standard practice. So this is going into the question that asked about how we roll the HEF out within our organizational structure. We use it quite often. We use it across all of our teams. We use it across those 4 content areas that I mentioned. We use it to redefine our vision and our purpose. Working from home, the dog is in the background, so I apologize. We use it to unify our products and services. And so we make decisions as an organization based on where a tool or where an intervention, sits within the HEF model. All of our contracts and grants are assigned to the HEF in some way, shape, or form. So we track our work at ETR based on where it sits in direct relationship to the HEF. So how do we know that our work is addressing some aspect of health equity is that we actually assign that to the work as we take it on. We use it as staff reflection on what health equity means, both personally and professionally. We spend a lot of time in our teams asking ourselves, how is this work personally and professionally lifting up a space of health equity? It is hard work. We spend time not only personally and professionally in our teams, but also in supporting those on our teams to sort of advance in their own career path as well. And we use the HEF as a tool for that sort of process. We measure our impact through the spheres of change. And so we directly look at ETR's work across the spheres of influence and how our projects and the work that we're doing actually have impact by measuring it through the spheres. And we use it as an educational tool for funders and partners. In terms of mapping across organizations and the way that we specifically use it at ETR. So we think about what's the primary outcome of interest of the work that we're doing, who's our priority population. Do the projects that we take on explicitly change or support a policy or practice at institutions? Do they build the skills and capacity of professionals or our peers or partners to support the priority population? Does the project explicitly support the development of networks and connections amongst the priority population? Does it modify the attitudes, the skills? Does it employ strategies that account for physiological factors? We take the HEF and use this across all of our work. And so we ask ourselves these questions as we're thinking about the activities, the projects, the partnerships that we're engaging in. And we ask ourselves these questions constantly as sort of a rule of practice, even as we are engaged in the work. So again, we've used it to redefine our purpose, unified framework across our products, a method to identify gaps in our work, a staff reflection tool on what health equity means personally and professionally, and how people can engage in that in their own lives, and then measuring our impact through the spheres of influence. So I want to spend some time talking about or thinking about how we can, us on this call, use HEF as a reflection tool. It is a place of reflection, or how to even think about what reflection tools might be needed in your own work, in your own organizations, to think about how health equity is being infused into as a regular practice in your work. So what systems or institutions excuse me, so we're going to explore how risk and how protective factors influence health outcomes. So within the systems of power framework, we think about what systems or institutions or policies impact this outcome. How do systems, institutions better support outcomes, and how these systems or institutions either create barriers or take away barriers from outcomes is one way that we think specifically about our work at ETR. Are there ways that you all think about your work at ETR, in your work and your research around addressing systems of powers? Just giving a few minutes to type into the chat if you have something to type into the chat. Thoughts on how you address systems of power in your own work? Opportunity for reflection. How do we address relationships and networks beyond the individual who has influence over this outcome? How do families or friends or partners or support systems better support outcomes? And how do relationships with others enable harmful behaviors or create barriers to better outcomes? Taking a moment to reflect, how does your work address relationships and networks? Any examples? Yes, harm reduction. It's a good one. In terms of individual factors, what knowledge, attitude, or values do individuals need to gain better health outcomes? What behaviors lead to better or worse health outcomes? I know that there are a number of folks in here doing specific research in terms of behavioral outcomes, research on community outcomes. What are some of the ways that you were addressing individual factors in your work as it pertains to health equity? Any examples of current projects? No one wants to talk about their projects? I can talk about one. ETR is currently the evaluation partner for a large-scale initiative to address HIV in the South, across 16 states in the South. And we serve as the evaluation partner to the implementing partners that are implementing services across capacity building, harm reduction, and behavioral and mental health, stigma and discrimination, and faith-based programming. And so part of our role is to not only track what's happening across programmatic areas, but also to sort of support and hold the work and lift up the work so that the funders, the programs, the community partners that are implementing this work can have a better sense of how their services are having impact in the South as a whole. Any other examples of programs or research that is occurring? I love that. using navigators as a bridge between providers and patients. Awesome. And then thinking about psychological pathways, physiological pathways, excuse me, how does a person's development or physical and cognitive ability impact this outcome? What role does trauma play, for example, in achieving better or worse outcomes? Any examples of how you all are thinking about physiological pathways in your work? Nice. So let's apply it. Here's some examples that I want to walk through in terms of how we can potentially think about the HEF in our role as researchers and as scholars. And so I'm going to walk through some examples and hopefully have you all share some examples of how you might do this as well. So with regards to addressing systems of power, one example is thinking about how a study looks at guaranteed income to Black moms. I know that there's a lot of work that's being done around guaranteed income or those kind of sort of structural ways to think about how do you address economic disparities as a way to sort of address health equity. Yes, I don't think about it as physiological, but addressing literacy limitations is important and not much discussed. I think that's a really spot on observation, particularly in terms of, I've been thinking a lot about literacy and I think we all have as it pertains to COVID and how there was just so many missed opportunities for thinking about COVID literacy across the spectrum of how COVID was handled in the United States. And so I think that's a really great point. Another example of addressing system of power would be a thing like a rapid assessment, which addresses health departments and their policies and practices to reduce racial inequities and vaccine distribution. Any other examples of how you might be addressing or thinking about systems of power in your work? And you don't have to type them in the chat, but maybe you're thinking about them now and how you can apply that sort of lens around systems of power in your work. I think about relationships and networks. And I think everyone on this call knows that our relationships within our research, particularly around our community partnerships, are the root of much of the work that we do as researchers and activists, and how we think about that is incredibly important. And so thinking about sort of the long-term availability and of support to advise your CBO partners that you work with, you know, sometimes we see a lot of, you know, the push as it is around funding and around where funding gets driven, that either relationships are not tended to because we're, you know, it's that push for that funding and we've got to, you know, fund our research and we've got to continue our line of work. And then also there's a way to think about those relationships beyond the funding. And I'm sure many of you do that as part of your own work in terms of being available to advise and support your partners on their projects, connecting them with other researchers or scholars, thinking about the ways that you continue sort of that application of relationships and networks. I'm going to push a sort of, I hope, interesting recommendation around relationships and networks, but, you know, thinking about your partnerships to have that coveted first author role. When you think about your papers and your and sort of fostering those types of relationships, I know that there are a lot of folks that are moving in that direction about thinking about relationships, but it's a big one, right? Because that tends to touch on areas that are tricky for fostering relationships between community-based and academic researchers. But what would that mean if that would be something that that could be front and center in your approach around relationships and networks? In terms of individual factors, research that highlights the strengths and resilience and a critical qualitative stance so that the stories and the context stay relevant. This is a really big one for me, particularly as a qualitative researcher. A lot of times in terms of our work, we see that the way that qualitative research is used, it's in the formative phases, right? Like we do our focus group, we do our IDIs, we get that qualitative information to set the frame for our work, which is also incredibly important, that drives the development of our core research questions and what we need to learn. But how about if we start to think about how qualitative research really embeds itself in the IS framing and that it becomes a routine part of those plan, do, study, act cycles. And so that you're doing sort of that contextual checking in throughout the course of your work. Does anyone have any examples of how they've used that in the past? And then in terms of thinking about the psychological pathways in HIV research, particularly in terms of thinking about prevention to scale. And as I mentioned earlier, ETR is the largest provider of health education materials in the United States. And so part of the way that we think about our research is that once we have findings that are salient and important, that we drive those into sort of a scale-up approach around how do we get that information out. Health Smart, which is one of ETR's educational curriculums, is used widely in public health schools around the United States. Particularly, it's a middle school curriculum that addresses health education and sexual health education for 6th to 8th graders. And that's actually now currently in all of the middle schools in LUS, Los Angeles Unified School District, as well as all of the middle schools in New York Unified School District as well. Implementation sciences and what facilitates delivery with an equity lens. Yes, I like that a lot. So really, I'm going to ask folks to take a moment and either write in the chat. I would prefer it if you write it in the chat so that we can maybe share some actions with others on this call. One action that you would take in the next 3 months to apply a health equity lens to your work, and given some of these examples and given the HEF and given the framing. I think that's a great question. One action that you could use, taking a moment to identify one action. I only see one action. Any other examples? I think that's a great one. Intentionally using it within your study teams or your partnerships. Having agreements about authorship on the front end of the work is another one. Yes, I think that's fantastic. One example that we've used in the past with guide analysis is that we've done joint analysis with our community-based partners. We actually, in a project that I worked on a few years ago, we actually taught the research assistants who were collecting data at the community-based organization how to use SAS. And then we actually had them run the statistical analysis for the basic demographics themselves. Takes a lot of work to do those kinds of things, but they walked away with the skill set. Any other ways that you can think about applying health equity in your work? Yes. Being intentional and self-reflective when pursuing your work. Thinking about how you as the individual researcher hold a space of power in your work, particularly when you're working with community-based organizations. Yeah. Health equity is not just a desired outcome, but it's a continual process. It's one that we have to stay engaged in at all times. It's an action. It's a desire to do things differently in yourselves as researchers, but also to do things differently and to show to your partners and your organizations and in your work that we can do things differently. So some of the resources that informed this presentation are listed here. One in particular that I wanted to point out, which I think is an incredibly useful journal article that came out last year by Dr. Lisa Boleg, is that last one there, The Master's Schools Will Never Dismantle the Master's House, 10 Critical Lessons for Black and Other Health Equity Researchers of Color. If you've not read that paper, I would highly recommend that everyone on this call read that paper. Very important work as we all think about how we as researchers and scholars and activists push the envelope in terms of the places that we enter as we do this work. And that concludes my presentation. So thank you very much. Shouts out to our HEF working group at ETR, Drs. Renata Charles and Dr. Amy Peterson for their support in this presentation. And I will stop and take questions.
Thank you so much, Dr. Udoh. We'll
Yes.
take some questions. We will unmute the participants. And if you can raise your hands or just alert that you have a question, we'll take your live voice. Are there any questions? Janet Myers, did you have a comment or a question?
Did you hear me? Did I unmute myself?
No, you didn't. Go
Hi,
ahead.
I don't mind being called on. I love this work. It's incredible. I'm particularly impressed with the way you use it in your organization to sort of do course corrections and support people professionally. I think that's awesome. And I was wondering if you could just think of an example that to you just really struck you of how when you started using this or as you've been using it, how it's really made a difference in your own work or even around, even the people that you supervise. So
Yeah.
it's sort of personal to you.
Yeah, I think that, thank you for that question. I think for me, how it's applied itself in the way that I operationalize my work. is that, and Janet, you know me well from all kinds of experiences. And so I'm the atypical researcher, right? I am the researcher that chose a non-traditional path in terms of my work. And what that has meant is that I've had a lot of different kinds of experiences that have allowed me to interact in different ways across the world with different teams. And it has also meant that it's been difficult as a researcher, particularly as a researcher of color, and how you get viewed about what your contribution is to the work. And so I think for me, the way that it applies when I use the HEF to my work is that there was a comment in the chat about everybody's brain matters, right? Like I have a rule on my teams that that nobody can leave a meeting quiet. Like if you don't talk, like there's no one talking on this chat, on this talk right now, which sort of bothers me a little bit because of like what are the brains on the table, right? And so in my work as a researcher, everybody on my team talks. I never have a call where someone's sitting on the call silent. And it might be that you're silent because you don't have anything to say, but I'm going to ask you, are you silent because you don't have anything to say, or that you're thinking about it, or you got to come back to me later? I'm going to allow that opportunity so that everybody knows that no matter what they're thinking, no matter what they don't know how to ask, or whether or not they're not clear about what's going on, that there's always an opportunity to engage. And I think that's incredibly important that we as scientists hold a space like that for everyone that we work with, but particularly for your junior scientists, for your MPH level scientists, for your community-based partners. Like everyone has to talk. Everyone has agency and everyone has voice. And as people who hold places of power in the research structure, it is on us to do that. It is us, it is not, so that's one way that it's applied in my work. Someone asked that I address the question. There was a question that came from Nina. I'm gonna try to scroll up, Nina, and see if I can find the question. Oh, there we go. In my work with community partners, we often have study teams that involve both CBO and university staff, and the CBO staff generally have lower salary ranges and less generous holiday vacation policies. Yeah, that's a critical one. What are the equity approaches to dealing with this? It's a really great question. I think some of the equity approaches that we have used at ETR, and that I know that are also used pretty commonly with for example, the CHIRP funding mechanism. But some of the equity approaches that we use at ETR include having that sort of open dialogue about, like, you know, how, first of all, how expensive things can look and be, right? Like it's expensive to use researchers, and a lot of times those budgets are not necessarily, we don't, like, you know, blast our salaries to, you know, our entire teams, but we're really clear about the context of how much things are going to cost. We talk about things like when staff need time off to do their work, and how that's not necessarily about you know, we follow sort of obviously the CBO practices around time off. We also follow the CPO practices around being aware of what's going on in a particular community to where the CBO might need to shift. I've worked on projects before where CBO partners have, particularly outreach workers, have been impacted by violence in their communities. And so that will shift some work, right? Because it could be that staff person is experiencing trauma because of what is occurring with them, and then that is impacting your ability as a researcher to get, you know, your deliverable done for whatever reason. But just having sort of open dialogue around that, I think, is incredibly important when those shifts need to happen. So I think those are some of the ways. I think some of the other ways too that I spoke about is that we intentionally do lots of skills transfer work. And that I've worked in spaces where to, sort of to address those issues around lower salary range or holidays. We do a lot of work for skills transfers so that those organizations and those individuals walk away with something other than just having been our partner, right? That they walk away with a paper. They walk away with a skill set on using SPSS. They've learned how to do qualitative analysis, and they've sat in a room and done joint analysis with us. And so that's a skill set that they have that they can then take into their other opportunities. And so really thinking about how skills transfer can support that engaged learning, but support sort of those disparities around who holds power within the work. Does that answer that question?
Yes, looks like Dr. Harara said yes.
Yes.
Thank you.
Yes.
Are there other questions?
I had a quick question. First of all, thank you so much for this talk. Very interesting, very useful information. I was recently in a conversation about kind of challenges getting funding for more kind of community-led efforts, particularly in the research space, and kind of thinking about ways. One thing that was discussed was, reviewers are often looking for a particular team composition for different funding opportunities. And so, how as applicants can we, make sure to really uplift our community partners and community investigators, and also, maybe think about ways to change how how that review process and the funding mechanisms kind of are structured, potentially advocating for changes at that level to kind of move equity issues forward in a positive direction. So curious if you have any comments about that.
Yeah, it's a really great question. We funders are hard, right? Like funders, and particularly in the research space, that can be a challenge. And I think some of the ideas and thoughts that I sort of put forward already, I think are ways that we can sort of build some infrastructure and some movement around that. And so again, that coveted first author space, right? Like how do you, as research teams that are working with CBO partners, decide that in order to sort of uplift the research and to uplift the CBO partner sort of lead in their ownership of the work and their ability to actually use that work to then go like support themselves or be in sort of considered in these sort of spaces as also relevant researchers. Sometimes it's about us, the researchers, giving up a coveted space in order to support that to happen, right? So that's one way that could be thought about. There are funders that have history around really placing or addressing that equity approach in their funding streams. And I mentioned one earlier that probably many people on this call are familiar with, but the CHIRP funding is one of those funding streams that's really sort of addressed that sort of equity lens in their funding. And that, there's a PI from both the CBO partner and there's a PI from the university partner, and they have equal footing in terms of decision-making around the research. And that there's transparency in thinking about the budgets, right? Like these are some equity practices that a particular funder out of the UC system is really sort of held harness to, that we hope to see sort of pushed at other funding levels as well. So there are some examples of how we can embed those kind of practices or see those practices occurring in real time.
Thank you so much.
Yeah.
Well, thank you, everyone. I want to take this opportunity to thank Dr. Udoh for her presentation today. I'd also want to encourage our participants to take a look at their website at www.etr.org. It's got great resources on there, including the links to some of the publications that Dr. Udoh has mentioned. In addition, if we can have you all complete the evaluation form that's in the chat, that would be much appreciated. So thank you all very much for joining us today.
Thanks, everyone.